Okay, Kelly, according to the Rice paper that you shared regarding exercise-induced hyperalgesia, it said that aerobic exercise induce widespread exercise-induced hyperalgesia, while resistance exercise induce local and global. May I know what is the difference between widespread and global exercise-induced hypoalgesia? Cool, great question. And the fact that you've gone and watched that tells me that you took some value of our session last time, because I think, did I get that one up, or did I put that one into the resources? I can't remember. But that is a really powerful paper that helps me with confidence for structuring working with somebody from an exercise perspective, because if we looked at the Bull 2020 World Health Organization guidelines, no matter what presentation someone comes with, right from acute or persistent back pain through to cancer, everybody's going to benefit from being able to find some amount of exercise or physical activity that can be adapted to them. So the clinical reason is all that would really change. Now, with what you're talking about there, local and widespread exercise-induced hypoalgesia, the metaphor that I would use for that when working with a client is the internal drug cabinet in the brain. And that is something that I put pain neuroscience education in for you last week under calming nerves, I think. And what that is to be able to say, okay, so if we were to do, you guys would be familiar with your neuro testing, so you would do sharp and soft discrimination. So if I had a pin here, I would test a pinprick sensation here, and I could test a pinprick sensation here on the other hand. And I could ask you, does that feel sharp or soft? And you'd say, yes, that's sharp, or it's soft. Okay, yes, that's sharp. I'm going to do the same thing on this hand. Is that also sharp? Yes. Does it feel different from side to side? No, it feels the same. Or that could be interpreted as, no, that pinprick on the right hand, that definitely feels sharper. That would be hyperalgesia, and that would be a local, could be a local, or it could be widespread. Now, what the exercise suggestion that you're talking about there is that we could do an exercise of the hand that could cause a reduced perception of the pinprick. So, for example, strength exercises in the hand could cause a local hypoalgesic effect in the hand. Unfortunately, for a lot of people who have persistent pain, is exercise in the body part that hurts actually causes them more pain. And that's not because the exercise is bad for them, it's because they've actually got a dysfunctional descended inhibition system. Their internal drug cabinet in the brain is actually where the issue is, not their hand per se. So in those instances where the exercise locally doesn't cause a reduced sensation or a reduced algesia in that body part, we could do exercising of this hand, or even something completely different like exercising on a bike to get the heart rate up, which would cause global reduced sensation without actually exercising the body part. So that's what that's talking about there, is we can have a local benefit by exercising the body part, or we can have a global wide-reaching increased analgesia by something like exercising a different body part. And my reasoning would be, okay, so we've got someone who's got a painful hand, or we've got someone who's got a painful back. We might start off with trying to do some exercises of the back, and they're saying that that's flaring them up. So I would use that mechanism of, okay, so we're going to not work on the back. For now, we're going to use this idea of the internal drug cabinet in the brain to do some leg exercises, or to do some upper body exercises, or some aerobic exercises, although that, unless we can explain that, might be interpreted as, well, why are we doing upper body exercises when I've got a back problem? Do something to my back. Kelly, does that make sense? If it doesn't, jump on and we can have a chat about it, because this is it's a great question. That's, you know, to your benefit if we do go, if we that you have gone away and had a look at it. Widespread and global is the same. Yes. Yes. Local is the opposite. So local would be a targeted, you know, we would do, for example, when we get the tendinopathy. So I had a tendinopathy of my patella tendon, which is specific local pain on my patella tendon or my patella ligament from a repetitive strain nature that I haven't been able to recover to. So I've got a very local pain on my patella tendon, and I would want to maybe start by doing isometric strength exercises on my patella tendon to give pain relief in the patella tendon. That would be a local. I could also try and clinically reason that going swimming and getting my heart rate up could cause a widespread descending inhibition. But again, when we look at something like patella tendinopathy, we probably need to do something local to try and get some analgesia there. When it comes to something like back pain, neck pain, it's going to be really trial and error as to what works for the person, because there's not a research guideline that tells us that targeted exercise, a specific exercise, is most important. And I've got a paper for you guys this week, which probably lends itself for me to pop up now, is this one here, which is the Cash-In 2021, was pubbed 2 weeks ago, and I had to work seriously hard to try and get hold of this because it's not even accessible on Sci-Hub at the moment. But this is about making exercise count, considerations for the role of exercise in back pain, and it is a stunning paper. It is everything that that I've been reading in the field in the last 10 years, and well, the last 5 to 10 years, and been applying for the last 5 years, all put into one nice short paper as to what we should be trying to do from an exercise prescription perspective. But I'm not going to walk through that. I'm going to pop it up there and just leave it for those of you who are interested in exercise rehab can consume that and reach out to me if there's anything that speaks to you, because that is quite a stunning paper talking about the broad approach to back pain and exercise prescription that we're trying to, well, at least I'm trying to expose you to. So that's local and widespread or global. Is that cool, Kelly? You won't have been the only person who would have benefited from that distinction. Okay. Another question: how do you differentiate from hurt does not equal harm and when hurt is actually causing harm? Fantastic question. And that is going to be something that I will allocate probably a whole week to, and I'm going to touch on it a little bit today. But let me just look in the articles that I put into your week 1. Adaptive pain.
Luke, sorry mate, which module are you uploading these materials in? Because I can't seem to find the module or the content.
So did you not see any of the stuff that I put on from last time?
I seen a notification, but I'm trying to find it now. And I just
go on to chiropractic clinic 2020 21 21 22.
I've got it. Thanks.
And you should see my folder, and I tried to organize everything for you in there. Do you see it? You see it?
There's a load. Is it where there's loads of folders and it's near the bottom, is it?
So as you go into learning materials, I'll just walk you through as I'm going through it. Learning materials, as you go down, you will see Luke Davis, contemporary rehab weekly content. And then at the top, it says class 1, 21, 22. That's the only thing that's available.
Yeah, I can see it. I can see it. Thanks.
So if you go in there, I organised everything from last time, so that's going to look quite a lot if you try and do that in one go, but I did that to try and spread it out for you over 3 weeks. But resources to work through there in some sort of logical order. But your question, Kelly, is going to be something that takes me into something useful to be able to try and get across today, which is distinguishing whether something is helpful pain or something is unhelpful pain. That's exactly what you're asking there. Is this pain? Another way of saying that would be, is it adaptive or is it maladaptive? And for that reasoning, we need to review something that I put on in week 1, but you maybe haven't got round to being able to see it. So I'm going to walk you through it again here now, which is this article here I put, which is a walkthrough of identifying the primary pain type. Now, there is 3 primary types of pain that we have to be able to try and classify in terms of answering that question that you just said there. Is this pain that I listen to, or is this pain that I need to be able to challenge? And the first type of pain mechanism is your nociceptive, and that is where we have our danger receptors. They are in all of our tissues, not strictly true, we don't have them in our brain, but in all of our tissues in our body that are sampling to be able to look for threats, mechanical threat, thermal threat, or chemical threat. And what they do then is, if there is danger, i.e. there's trauma, there's inflammation, they will set off the cascade of information to send danger messages in and to our central nervous system to process it. That I've put in as the pain neuroscience education in week 1 of the alarm system. Okay, now that is most commonly associated with the tissue-based mechanism. A lot of people confuse, even in the industry, even right up to the most highly regarded medical doctors out there, people still confuse nociception and pain. And that is a big, big problem, because treating nociception and treating pain are very, very different. Okay, but nociception is about threat to tissues, and that is what that is going to be sending information to the central nervous system. Okay, so neuropathic is the second type, and that is where we have an injury to the nervous system itself. That's the nerve root injury. That is where we have a herniated disc or something that traumatically impacts on the nerve root, can cause the sciatica and the leg pain. That is what most people would associate with sciatica. And that's maladaptive from the start, because it is the nervous system, it's the alarm system that is injured. So whilst it can cause an extremely debilitating pain experience down the arm or down the leg, the pain experience is wildly disproportionate to the amount of injury, which you could scan and see that it's a small disc bulge that is on the nerve root. Really, really important to be able to get our heads around that, because the neuropathic pain type and the nociceptive pain type are going to be very different. The neuropathic pain type is going to be in our 5 to 10% of presentations. There is a 1% likelihood of someone having a red flag. We don't want to miss that. So we put into your notes last time how we would have an index of suspicion of questions. Use my article if that helps streamline that for you. Have those questions in front of you to ask. And so we've got nociceptive as the tissue-based mechanism, neuropathic, which is the nerve root. Then the final one is basically everything that isn't that, and that used to be called central sensitization, or a more contemporary wording would be nociplastic. And if you read this cash-in paper that I put on this week, astonishing paper, absolutely beautifully places this as I'm describing it here now. But being able to help you decide which one it is that you're primarily working with, because you are likely to have an element of all of them, from the tissue-based one to the nerve root one to the central one, which is the nociplastic. There's going to be adaptations and changes that happen with any pain state. But in our first step is going to be, I'm assuming now you've ruled out red flags, you've done that part. Now we're trying to identify the primary pain mechanism. The first part is the most serious one of those three, is going to be the nerve root. Okay, and the nerve root is going to be whether we want is where we want to try and rule in or rule out neuropathic pain. Okay, now neuropathic pain, we can do that. I'm going to come down to the features that I've put into this article. Central neuropathic pain. We can do that because that is this, as I've outlined in this description here. It's where we're going to have a history of a lesion or disease to the nervous system, major a trauma, a mechanism of injury that is going to be in our exam. We are going to be able to see things like the reflexes might be flat because that nerve root is being compromised. We might see characteristic sensory changes like paresthesia or pins and needles that conform to a dermatome, or a weakness that might conform to a nerve root. And they will typically be one nerve root, although that's not set in stone, that as a rule. And the presentation is often logical. So that's when I say, when we say logical, it's going to be down the arm and maybe it's in the thumb and the first finger, or it's down the back of the leg to the sole of the foot, or the top of the leg on the big toe. When we look at our charts and our maps around nerve roots, those are going to be quite identifiable, often described as burning, shooting, or pricking. Now, we want to be able to rule that out first, because we can do our neuro assessment to be able to say whether we think the nerve root is being compromised here or if it's being irritated, to then be able to suggest how or what we might interpret that pain to be based on. That's going to keep tying this back to your question before. We need to be able to say that hurt doesn't necessarily equal harm if we're reasoning that the nerve root is compromised, because, as we said there, the pain experience is so much greater than the size of the injury. We need to be able to get little bits of movement, of moving the nerve roots, like some flossing or neurodynamics that you would have had some exposure to be able to try and do some things like general exercise to get that widespread analgesia. That might hurt, but we're going to have to suggest that people are going to have to be able to lean into that and work with that a little bit. Now, the nociceptive pain, which is your tissue-based mechanism, that's what most people would associate all pain to be, is nociceptive damage. And here we're going to have a history of damage to body tissue in the last 6 to 8 weeks. Okay, so what in the lead up to your back pain, was there one moment where you felt something happened? Was there a clear injury? There's going to be something that be able to explain or to give a connection to a nociceptive driver, and that we get that from asking and taking the history. This will classically settle down as healing phases pass. So if we were to look at the explain pain in under 5 minutes video that I put on, most people's back pain is going to settle within 4 to 6 weeks. Some people it's much shorter than that. Then other people, it will go on much longer. But most tissue healing phases the pain in nociceptive will follow tissue healing phases. Like an ankle sprain, you will feel that pain as you load the ankle and you'll back off, and as you go through the healing phases, you'll be able to gradually just get going. And that would be listening. That would be, to connect to your question, that would be not applying hurt doesn't equal harm. That would be, to use your exact wording, that would be hurt is actually causing harm to some extent. So that would be what reasoning would be around that as your pain mechanism. There is often described as sharp, aching, or throbbing, and we often have the things that are associated with inflammation, like inflammation, swelling, redness, etc. Think about an ankle sprain. It's what most people can easily connect to the acute signs of nociception. Now, we've gone through neuropathic there. We've gone through nociceptive. So is this the same as the finger stretch and ice cream headache versus bruises cut example you gave in your videos? That is, yeah, that's the examples I give to be able to help people get on board the fact that pain is never equal to damage. Pain is not about damage. There is tissue damage is one driver that can set off the alarm system. It's one threat. To use that language is easier for us to then broaden our perspective around the other things that can set off the alarm, because whilst tissue damage can be a threat, being depressed is also a threat. Having a nail go through your boot when you're a builder and you see the nail coming right the way through is a major threat. The evidence is that that nail is going through my foot, and the famous story in the BMJ of the builder that couldn't get pain relief via any of the medication until the gas and air, etc., until they took the boot off and realized that the nail went straight through his toes, didn't even touch his toes. If you're unfamiliar with that, then have a look and Google that. But the threat was there. That was enough to be, that is what it would explain whether we need protection or have a pain experience. So pain is never equal to tissue damage. But your question before is, sometimes there is tissue damage, there's an injury, and we want to be able to listen to that pain rather than trying to poke through it. And I think that's a really, really key thing to get our head around. I've got a little case that I'm going to share with you today that I want you to be able to apply this thinking for application of this. But ice cream headache, bruises and a cut that you didn't see where it's coming from. Can somebody think of examples of either of those, so that we've got tissue damage and no pain? So a cut and a bruise, can't remember where it came from. Or the opposite, pain and no tissue damage. Ice cream headache. If you can think of two extreme examples like that, it helps us to be able to just untangle the fact that pain is never a reflection of tissue damage, beyond exception. That is something that is always an output. So the final one that is to be able to get our head around is this final one, which is a central or a more contemporary way of framing this, is nociplastic. So this doesn't seem to be changes in the tissues, but there's no evidence of the nerve root being compromised. So we haven't got neuropathic pain. That this category basically means anything else. Changes anywhere in our nervous system, from the peripheral nerves through to the spinal cord, through to the brain. This one has no history of an injury, damage, or any lesion. This one doesn't have a typical pattern when we do our neuro exam. It doesn't conform to a nerve root. It doesn't conform to a peripheral nerve. It's aching, it's vague, it's dull, it moves. This is anatomically illogical, but that, when we understand what pain is about, is much more typically what we see. This is 90 to 95% of your back and neck pain presentations, i.e. there is no clear injury, there is no clear nociceptive explanation for pain. And this is why this one is so difficult to manage, because most people get treated when they come for neck and back pain, which is the leading reason people are off work, burden of cost to society. Because this one, we have to take a broad perspective, because if you're searching for a trauma-based, tissue-based explanation for this that leads to somebody backing off, then unfortunately people do that for a very long time, and they end up with all the implications of backing off and not hitting general physical activity guidelines, or doing things that are meaningful to them and enjoyable. So that is all about, when you've got your next patient in front of you, and this is what my challenge to the guys on my internship was this week, is I've got to come to a point that I'm going to be writing down in my clinical reasoning or my clinical impression, is this pain experience of the person in front of me adaptive or maladaptive? Not, is this pain reflecting tissue damage, or is this pain not reflecting tissue damage? Because that's never the case. It is this pain adaptive, i.e. is it helpful for me to back off from this pain, or is this maladaptive, i.e. this changes somewhere in the nervous system that's going to need changing or challenging or doing something a different way? Because that's going to tell me when someone has come to me, if my discussion with this person is, oh, that back pain when you're doing that activity, let's listen to that and let's just back off and come back to that another time, versus we're sore but safe, we need to touch it, nudge it, tease it to be able to try and work through that task, and actually doing it a little bit more might not make our pain worse, but we can actually do the task. And that's a very different approach in terms of the reason when you're working with somebody, that will always come back to and hinge off your reasoning of, is this adaptive or maladaptive pain? I'm going to take you through what I've been wondering, Angelo.
So yeah, I've been wondering. So I got a patient with, and I feel the same way. I'm trying to sort of find out whether or not to try and sort of tease the pain, or whether to avoid the pain, and I don't quite know how exactly to decide that. You know.
That is the $1 million thing. That is the hardest thing for all healthcare professionals. And even those that, if you look and speak to them and they come across really confident, let me give you confidence that that is the hardest thing to do in practice. Knowing, and that's always got to come back from a thorough history and a thorough assessment, because you can identify the nociceptive mechanisms if you've done that thorough job in your assessment. There'll be an injury that you can then go and look at and say, oh, this person has pulled their hamstring. I can go into Google Scholar and look at a systematic review of hamstring injuries and plans of management. And that's then just guiding someone through tissue healing phases to be able to get back and then increase the loading, if you're familiar with any hamstring exercises, back to whatever they need to do, running, for example. So the fact that you're wondering that question and you're thinking about that is a really, really good place to be, because that is where, even when I'm working with anybody now, I'm having to wrestle with that myself, and you don't always get that right. But having a confidence in, even if someone has cancer, that the physical activity guidelines say that they are going to benefit from physical activity and keeping them moving, gives me confidence with saying, okay, so maybe I'm not going to move this body part today, but we're going to move something else. And then we'll bring that body part back in, because we know that no matter what the condition, keeping your general well-being is going to have a positive impact on not just that, but on mental health, on obesity, weight management, all of these different things that comes into it. So I'm going to share with you a client presentation that I have their permission to be able to share, because this was last night. And this client was deadlifting come on. All the way through, come on. 2 minutes. Go. Come on. All the way through, come on. All the way through, come on. 2 minutes. Go. Come on. So last night, this person, if you didn't guess was me, was deadlifting to start a new training block and building up to be able to hit a single rep, because that was the basis of the training for the next 7 weeks, and working up through the weights, and then got to this weight here, which then, as the bar come to the knee, I heard a almighty sound in my lower back that was petrifying, to the point that I had to put the weight down. There's no chance of me being able to fight through that. And I have injured, or I have back pain now as a result. So this was last night. So this client is coming to you, and the pain is on the SI joint, and you have to now decide around a diagnosis of your primary pain mechanism. Who would be comfortable to pop into the chat of the three pain mechanisms we just went through that we could be primarily thinking about when someone's coming in and they're describing what happened yesterday, and they maybe even got the video, like I've put that there for you, as to what would be the primary pain mechanism we might be thinking of the three that we just went through: nociceptive, neuropathic, nociplastic. Nociceptive, absolutely. This is where someone is giving you a clear injurious mechanism that's in the very recent lead up, and it was immediate, and that would then lead you to be able to clinically reason that there could be a nociceptive tissue-based injury, because there's a very high load task going on here that we don't know if that's high load for this person without more information or not. But that would be a very justifiable reason. Now, I was petrified, and I'm still in that phrase, because this happened last night, and I've never had that on a deadlift before. I've been training deadlift very, very regularly now for the last 7 months, so it's not a new exercise. But it felt like I would imagine many people to say, "Fuck, I've just blown a disc." That's exactly what it felt like, and it was loud, and it was right at a critical point during the lift. So what is also, as a clinician, would you want to be able to rule out as a pain mechanism based on that information there as well? What was the first thing in that pain mechanism I said is the most important one to be able to rule out after red flags? Neuropathic, exactly, nerve root. And that's exactly where I'm at. And the second that it happened, I'm walking around and I'm aware that that is a very plausible mechanism for being able to injure a nerve root. And it is also very plausible that that won't come on for 2, 3, 4, 5 days after the injurious mechanism. So if you're my healthcare professional now, I am absolutely desperate to carry on training, but I could not carry on, and I had to stop, absolutely gutted. But I now need to ensure that I am not going to moving into a neuropathic pain state where there could be inflammation now going on in my low back that could lead to my nerve root becoming compromised, and that would be a neuropathic mechanism of pain. That would be different to nociceptive. I am hoping that I've got a nociceptive pain mechanism, because that means that I could just let it settle down and gradually get going. Neuropathic can really, really linger, and people who come to you with leg pain and radiculopathy will describe often a pattern that it comes and goes, and it's often never the same again once you've injured a nerve root. So that's one little distinguishing feature from your clinical reasoning of someone's come to you, now my pain at the moment is right over my SI joint, I've got no leg pain. But your back of your head, your workup and your discussion would want to be, right, I've got a person that I think is nociceptive pain, so my advice is going to be, right, let's stop doing the aggravating activity, let things calm down, gradually get going. But at the back of my mind, I'm thinking, right, there's also a possibility that this could be a neuropathic pain mechanism, and in a mechanism where a disc could injure a nerve root. It doesn't mean that I want to freak out and suddenly mean that that's like in some way a more, you know, catastrophic thing than injuring any other tissues. It just means that the plan of management and the timeline is going to be slightly different, and the expectations that I would need to have of how long things are going to take would be different. That is not going to be the majority of people who are coming to you with back pain. the majority of people aren't going to be having a really clear. Most people, they'd like. I wish I could have just had a moment when I was lifting something heavy, because it just makes sense why I'm in pain. Most people want that, but they don't have that. They've had back pain that has been coming and going, and they develop movement patterns that are painful, and that is often really frustrating for people to be able to get their head around, and being able to then probably lean more down the track of nociplastic pain is going to be where we then want to be able to touch it, nudge it, tease it, and be able to get going. Would you say to me, coming to you today, to bring it back to you, Kelly, are you going to be saying, because now at the moment now for me, even sitting here is hurting, bending down is an absolute, bending forward is an absolute no-go, that really lights up my pain. Are you going to say that, do you think that it would make sense for you to say, look, hurt doesn't equal harm, just keep bending forward and see how you are at the end of the day? Would that be what you'd be suggesting based on the information you've had? Kelly, you asked me a question, I've asked you one.
No. So I probably avoid like aggravating movements initially, and then gradually do some graded exposure to go back to doing the things that the patient loves.
Good. That would be based on reasoning that, okay, you've just injured your back, there's pretty tissue damage in your back, we're probably going to let that settle down. Don't worry about it. Let's keep a nice upright back. Let's just let things calm down, and we would be able to get going. And that's exactly, I think, what you sort of said there, which makes sense based on a nociceptive mechanism. But if I didn't have a clear injury mechanism, or I had this, but I'm coming to you a year on, your discussion might be a little bit different. You're not going to, well, hopefully you're not going to be, you're going to be reasoning that I've gone through healing times, and you're going to be suggesting, well, we probably don't want to be carrying on waiting. We're going to need to find a way to try and get going with this, and to be able to maybe start bending down again in maybe a different way, and see if we can do that. And I went through associative learning as a pain neuroscience education for that in last week. And Tom's put in a great point there for working with someone like me now is going to be, yeah, okay, work on what you can do, develop on train the upper body. That's also going to get that widespread reach of analgesia, etc. So hopefully a nice carryover, whilst also meaning that I can still keep focus. A lot of people that you're going to work with, they're not going to be coming to you and saying that they train and they really, really motivated to be able to train. You're going to be trying to motivate them to be able to start doing something, to be able to have some of the physical activity benefits of aerobic exercise, of getting stronger, of doing things that they enjoy, of working on their mobility and their capacity to be able to do things. So that's where we need to have a broad clinical reasoning skill set for working with those people. Now, I put on your Blackboard this video, which I use in reporter findings to help get this across. I'm going to play this, and I want to hear if you can hear it. No, that's not sharing. Let me just try that again. Share screen. Chrome tab, understanding pain in 5 minutes.
Everyone agrees that pain is a universal human experience. We now know that pain is 100% of the time produced by the brain. This includes all pain, no matter how it feels, sharp, dull, strong or mild, and no matter how long you've had it. You might have had it for a few weeks or months. This is called acute pain, and it's common with tissue damage, say from a back injury or ankle sprain. And generally, you'll be encouraged to stay active and gradually get back to doing all your normal things, including work. Or you might have
So at that point there, I would stop that to be able to connect it to the person that I'm talking to be able to say that that deadlift mechanism would put us into this category of acute back pain. That means that we want to be able to just let stuff calm down, stop doing that provocative thing, and we would try and get going again over the coming weeks. And we would look at and draw upon some of the research to be able to say over the next 3 or 4 weeks, we'd hope that that really calms down. Very frustrating for me, but when I've got a competition in 7 weeks, but that would be what you'd want to be talking around, the acute mechanism of pain. Okay, if it is a little bit echoey and you can't hear it great, then it is going to be it's on your blackboard already. I'm just showing you how you might use this to be able to clinically reason for a couple of different approaches with back pain and neck pain, or in any pain. I use this for any pain. Because the rest of this video now, I'm going to let it run, because this is going to open up for, so everything we're talking about here now would be our nociceptive pain mechanism, that acute management. Now we're going to be moving on to the nociplastic, or the persistent mechanism.
Had it for 3 months or more, and this pain is generally called persistent or chronic, because in this type of pain, tissue damage is not the main issue. What's less clear, though, is when you're told you have chronic pain, is knowing what's best to do about it. Well, in Australia, chronic pain is a really big problem. In fact, 1 in 5 people have it. Having a brain that keeps on producing pain, even after the body tissues are restored and out of danger, is no fun. Some people say it still feels like they must have something wrong. But that's just it. Once anything dangerous is ruled out, health professionals can explain that most things in the body are healed, as well as they can be by 3 to 6 months. So ongoing pain being produced by the brain is less about structural changes in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try and figure out what's going on, you need to retrain the brain and nervous system. To do this, it's helpful to look at all the things that affect the nervous system and maybe contributing to your individual pain experience. What can help is to look at persistent pain from a broad perspective, and by using a structured approach and a plan, it's less likely that anything important will be missed. Let's start with the medical side. Firstly, taking medication can help, but only to a limited extent. It is the more active approaches that are necessary to retrain the brain. So using medications to get going is okay, and then mostly they can be tapered and ceased. Some people also think surgery might be the answer, but when it comes to a complex problem like chronic pain, surgery may not be helpful. So if you're thinking of surgery, it's best to get a second opinion, and remember to consider all the things. Next, it is helpful to consider how your thoughts and emotions are affecting your nervous system. Pain really impacts on people's lives, and this can have a big effect on your mood and stress levels. All those thoughts and beliefs are brain impulses too, but you can learn ways to reduce stress and wind down the nervous system. This helps with emotional well-being and can reduce pain as well. The third area to consider is the role of diet and lifestyle. Now, it turns out that our modern lifestyle might not be so good for us. In fact, what we eat and how we live may really be contributing to a sensitized nervous system. Looking at all the things like smoking, nutrition, alcohol, and activity levels, and seeing if there are any issues is a good beginning, and these things can go on your plan. Then there's often enormous value in exploring the deeper meaning of pain and the surrounding personal story, by stepping back and looking at all the things that were happening around the time the pain developed. Many people with pain can make useful links between a worrying period of life and a worsening pain picture. For many, recognizing deeper emotions can be part of the healing process. Last but by no means least is physical activity and function. From the brain's perspective, getting moving at comfortable levels without fear and where the brain does not protect by pain is best, and you'll gradually restore your body's tissues. So, to sum up pain, it comes from the brain and it can be retrained, and when looked at from a whole person or broad perspective, gives you a lot of opportunities to begin. So, get a helping hand if you need it, set a goal, and begin.
So that is the Explain Pain in Under 5 Minutes, where the first part of that video helps us to be able to explain to somebody if our reasoning is that we feel it's nociceptive, and we can give people nice tissue healing times and sensible information. Don't give anybody nocibic information. Optimism that things, if you're working with me with my deadlift injury there, Luke, this is frustrating because you have a goal to be able to, that requires you to deadlift, but you have an injury, we think, to your SI area. We hope it's not going to progress to a neuropathic or to leg pain, but that's something that we will look at and test again if that was to happen. But that is going to be gradually get going, calm things down, and back off from irritating those symptoms. We think that's adaptive, it's helpful pain, you just injured yourself. Versus the person who's coming and hasn't got a clear mechanism, their aches and pains have crept up, they come, they go, they're variable, and that is where we need to be able to have an avenue for a whole of life perspective, because it's not gonna make sense to have a fix me approach for a complex problem that is a nociplastic persistent aches or pains. So being able to use that video to open the door for the different things that people should be exploring with our help as a healthcare professional is what all of those different parts there, stress physiology, sleep, diet and lifestyle, these things, meaningful activities, worries, emotions, are the hallmark of a holistic approach. That is what we're going to be making much more important. Don't get me wrong, that is where people miss the fact that my pain is nociceptive, but now I've got low mood, I'm pissed off, I can't do something that's important to me, so all of a sudden those psychosocial factors are still important for me in an acute clinical reasoning of nociception. It just means that the importance of our waiting for the pain mechanism is going to be different in the second one, where that's going to be more like, so the second one, I mean someone who isn't coming with that acute injury. We are going to need to be able to say, we're going to need to work with this pain. We're going to need to move like a hook that's caught in a net. We're going to need to move into it to be able to get out of it. We're going to have to apply things like hurt doesn't necessarily equal harm to be able to get going. And I want to share something else with you, because this is where working with people over a period of time is going to be much more effective than drop-in sessions or single go sessions, because that's where people are looking for a fix, and being able to shift people from looking for a fix is what's going to be important, probably one of the most important things of someone being able to learn to self-manage, because they're not looking for a fix. They understand what they need to be doing, they understand where their resources are or their help is in their healthcare professional. And for that, I'm going to upload this week something called the Tasmanian Persistent Pain Booklet, which is a fantastic book by the group out of Australia as well, down in Tasmania, and it's 24 pages. So some people could read that over a coffee. Other people might want to do a couple of pages at a time, but it's for patients to be able to get them and shift them towards a contemporary biopsychosocial approach to being able to take a whole of life approach to their aches and pains. I use this and I give this to patients to be able to read. Hey, have a little read of this stuff following on from that video we just watched. When it comes to our next session, maybe just circle or cross a couple, put a star next to a few things that maybe spoke to you or the things that you were a little bit unsure of, and we can elaborate and talk a little bit further on that. That's within the pain education that I've uploaded, helps you to be able to elaborate a little bit further on any of those things. To be able to dial, I understand we can dial pain up and we can dial pain down. And this image here is a really nice one because it's challenging for people when we're saying, hey, look, I don't think that there's a nociceptive pain driver here. When most people, it makes sense. I've just done a fucking max deadlift. That makes sense why my back's injured. Most people need to have a plausible explanation. So being able to see that these changes can happen peripherally here, peripheral sensitization, they can happen in the dorsal root ganglion here, which is the first mechanism of central sensitization, or nociplastic changes right the way up through the spinal cord to the brain. So that's where, again, what nociplastic means is that there's change somewhere and we don't know where it is, and that's always almost irrelevant once we shift people away from what's the cause of my pain, because there often isn't one cause. It's a multifaceted emergent experience. So being able to take someone through these things, to be able to get them open the door for them to be able to explore a whole of life perspective. I'm not going to talk you through this now because we've only got a couple of minutes left, but I just want to take you quickly through what it looks like in here for the different visuals. There's things for turning pain up. So, you know, being run down, immune system, avoiding activities and things that you enjoy, not sleeping well, fearing the pain. At the moment, I'm in a state of a little bit of fear because I'm worried. I understand that the mechanism of my back injury is that could turn to a neuropathic pain. So I have that fear. So it's going to be adaptive that I have that fear until I have some evidence over the next week that that hasn't happened. So, you know, these things turn the pain experience up. The complete opposite turns it down. Seeing friends and family doing things that you enjoy, having a good grasp of the different life stresses that you got going on, exams, relationships, money, work, business, games, sport, whatever it is, sleeping better, making plans and being proactive, being strong and resilient, normal activities. These are the things that put us into the upward spiral. These things put us into a downward spiral. And us as healthcare professionals are really well placed to try and help people shift to these things and try and manage these things. This is what that upward spiral looks like, and it starts off with pain, and the first thing is understanding. Now, I know that you guys are limited in your access to rehabilitation because the suite's closed, and why I put an emphasis on us going about it this way in this class is because understanding pain, clinically reason to help somebody to be able to understand that hurt doesn't equal harm, that we can be sore but safe, and give people optimism and a good prognosis, actually is really liberating. You don't need to do movement or exercise. That's something that, you know, I would always put in every program that I'm working with somebody. But understanding and liberating someone to an understanding that empowers them to do things away from us, because they can then start moving and feel stronger and more confident. Less fear, then they can develop endurance, they can develop confidence, return to the things that they are. You know, it's really going to be important for me to return back to deadlifting as soon as I can. And then this upward spiral then just becomes self-fulfilling. And that's the rest of that is on there for you to be able to look through. So that I would suggest that if you look through that and understand that well, then you're better placed for giving that to somebody so they take a whole of life approach rather than expecting you to fix them, because that's a big pressure, and you're able to then elaborate on the things then in bringing it in and showing it to you. How do you go about doing that? Maybe you want to print it off, maybe you save it and download it so that you can email it to them. I would be wanting you to be innovative and creative in using resources to try and give people the best chance of being able to have a positive experience with their pain and with movement. Okay, so I will upload that. I will upload the Cashion paper again for you to keep perspective around what the evidence is saying. I will upload that deadlift video if that helps you to be able to clinically reason whether the person in front of you when you're seeing a client this afternoon or tomorrow is adaptive or maladaptive. Then remember my video and probably think about that one as adaptive, and then be able to remember the flip of that and the total opposite. I'm also going to upload another 4 pain neuroscience education videos that I've made, that is part of Back to Roots, that will include some things like envelope function, conditioning, stress physiology, a couple of my favorite things to be working on with a client in those sessions. And again, if you were to spread the material out over the next few weeks, if you're able to find it, Angela said couldn't find it earlier, but you know, if you can find it and you're interested in it, then by all means pace it out. So I want to give you the best chance of having more exposure with me, not just these 1-hour sessions, because as you can see, these absolutely fly. Any questions or anything that you guys want to cover or want to just quickly ask before we close the class? Tom, I've had a few athletes come into clinic with the belief that their wonky technique is dangerous and will cause harm. I take a lot of Instagram accounts that push a tissue dysfunction for everything as gospel. I've discussed and educated on pain science, etc., but they don't seem to respond. I feel like they might respond well if I direct them to some Instagram accounts that may bring the message home purely because they have lots of followers. Sam Spinelli is good, I found, and Greg Lehman. I mean, Greg Lehman's had a recent debate with that bodybuilder around technique and pain. Have you seen that one? It's about an hour long. And again, just look at the clash of beliefs there. If that bloke in front of Greg Lehman can't have his his perspective shift from discussing with Greg Lehman, then that is what we would call a sandstone misconception. So levels of misconceptions is something that I'm going to spend a week with you, because it's so important, because some people's perspectives you're not going to shift. Other people's you're a bit more malleable because they're open and we can chip away at it, and other people are a sponge for just being given good information. So there's a way that I want to be able to do that when I'm working or chatting with somebody, to be able to assess levels of, is it worth me even trying to shift this person's perspective? And if you can't wait for that, if you have a look on my YouTube channel, it's under something called Soft Skills, where we look at levels of misconceptions. But yeah, I would say that anyone like people who put out all the pain science stuff, so people like Adam Meekins, people like Ben Cormack, people like Aaron Kubel, people like Greg Lehman, that's going to be the ones that are putting out the challenge to stuff like the symmetry model, the asymmetry, the muscle testing, the correct technique. And of course, there's going to be a better way to be able to, you know, we're not going to be able to have time to go into the technique debate here now, but that's what in this video I've put in this week is envelope of function, which means capacity. It's all about the rate of change that we ask someone to be able to adapt to. So in my deadlift example there, my technique is what works for my body shape, and I've been very, very consistent with my deadlifting. However, my last 6 weeks, I've not been training for absolute strength. I've been training for 60-second sets. So I haven't, on the bar there was 240. I haven't lifted above 210 in the last 6 weeks. So when I look at it from a pure load management perspective, there is a spike in loading that could have caused that. There's other things that, you know, I was using a flexi bar, which is the one that bends because it's a competition bar. So as you lift it, the weights wobble a little bit. You know, those things would explain why I had a problem last night with a movement that I've been slowly conditioning to. And if we allow slow adaptation over time, then we overcome symmetries, differences in technique, etc. So my envelope of function video that you will watch in the materials might be something that you keep as a link saved somewhere to be able to share with someone that you think you could help shift them towards adaptability rather than biomedical structuralism. Is that cool? Good stuff. Enjoy the materials or not, and I shall see you in a few weeks. Cheers, guys.